there, and now we're up to cortisol. Okay, so we're continuing. This is Introduction to Bioidentical Hormones. This is just a survey, part 3, and we're going to talk about cortisol. So this is one that is frequently overlooked, and it's intimately tied to the thyroid. And so if you when we're looking at thyroid issues, you have to look at cortisol, stress hormone, also, because the symptoms are similar, but there's some subtle differetions, and we'll talk about what they are. Okay, so cortisol is produced in the adrenal glands. It's responsible for fight or flight. You know, this is you're coming around the rock, and there's a mountain lion, and either you're going to be lunch or the mountain lion's going to be lunch. That's when, you know, we got our heightened sensitivity.
Gotcha.
When the fight is over or the flight is over, the next thing that happens is that the cortisol or stress hormone is supposed to go down to extremely low levels. I always liken it to, and the patients seem to understand this, you know, these icons down here in the bottom right, they're sitting here if you need them. Like, you know, if something happens to the internet connection, you pop this up, you do what you need to do, and then pop it back down. And that's what cortisol does. Okay, it's our primary defense. And you know, there's something called the Pregnenolone steal syndrome. If you don't have enough cortisol, your body's going to take Pregnenolone, which is, you know, one of the substrates, and shift it to the cortisol pathway. And shifted away from you know, going the opposite route. And I'm going to show you that in 1 second. Okay. Major functions of circadian rhythm. It stimulates glucose and glycogen turnover. It aids in fat metabolism. It reduces bone formation. So remember, high stress, high cortisol, you're going to end up with you know, thinning bone. Gotcha. Decreases amino acid uptake. It increases sodium and water retention, so you're going to end up with peripheral edema. It's an insulin antagonist, so you're going to end up with you know, lower insulin levels, and if your body can't handle it, you're going to end up with higher blood sugars, and it has some immune suppression. So this is just a picture. This is, you know, the effect of stress. I think this is pretty good, you know, whether you like this guy or not. You know, here he is in 2008. He's young, he's vigorous, and here he is in 2016, 8 years later, after being president. And, you know, he looks like my grandmother, so grandfather rather. You know, I mean, there's wear and tear, and you know, you look at any of the presidents. I mean, you know, they look horrendous after 4 years or 8 years. So
right.
This is just sort of just an example of what stress does. Okay. Now, you know, remember, there's good stress and there's bad stress. We need stress to get up and do what needs to be done. But the bad stress is if you know, you're under a constant attack like that, that's the end result. Okay. So we're going to go through the steroidogenic pathway in detail. That's usually when we're done you know, sort of this introductory survey. So we're going to go through this chart from stem to stern. But what I want you to realize is that cortisol is part of the pathways where the sex hormones are developed. Okay.
Gotcha.
And when we treat somebody with testosterone, you're going to get a you're going to get a change. Usually it's a negative feedback in cortisol or stress hormone. Okay. When you treat somebody with estrogen, enough estrogen, either by it's converting, you know, if we're giving testosterone or if we're giving it exogenously, you're going to get, again, a negative feedback for cortisol, stress hormone. All right. So progesterone, on the other hand, and pregnenolone are going to feed cortisol. It's going to make it, you know, going to increase cortisol levels. One thing that I've come across over the years and seems to get lost, that you can keep it in your back pocket, when you have somebody who has, you know, high cortisol levels, stress hormone, is that DHEA is a direct antagonist of cortisol. So you find somebody with high cortisol levels, your reflex is to go to DHEA. DHEA will balance cortisol levels. And, you know, it's easy to do. It's over the counter. We use pharmaceutical grade products, but they can get it. It has a label in the dollar store, but they can get it pretty much anywhere. It doesn't cost a whole lot. So somebody who's having, has extreme, and it can be low. So also, but mostly they have, having extreme symptoms of cortisol excess. DHEA is your friend. Okay. So just keep that in mind. So the hypothalamus is stimulated in a response to a stress, and it can be an awakening. There's the cortisol awakening response is a stress. It releases cortisol releasing hormone to act on the pituitary to make ACTH, which stimulates the adrenal gland to make cortisol. And then there's a negative feedback that sort of keeps the whole thing in the loop. Over here, I have the serum lab values. But just keep in mind that we like using that reverse T3 as a proxy for it. Remember, we talked about that, right? I don't know if
as a proxy for
cortisol.
Okay.
Okay. Reverse T3 usually greater than 15. Is a proxy for a cortisol abnormality. Now, it could be low or it could be high, but you can look at that. You can look at the reverse T3 and be reasonably assured. It's a 90 to 95% correlation. You can be reasonably assured that your cortisol is or is not an issue. Okay.
Okay.
This ACTH. You need to draw it between 7 and 10 a.m. I mean, this normal value of 7 to 63, that doesn't really help us in any way, shape, or form, okay? But, I mean, you can draw it, and usually you want it less than, like 10 to 20 is usually a pretty good range here.
So it surges during the morning, right? So it's
Yeah.
higher than the rest
Going to be
of
higher, yeah.
Okay, gotcha. But the number that we're looking for is 20 to 30, did you say?
Yeah. You don't really want it more than that. So, okay.
Okay.
All right. So excess and deficiency. So these are the summaries that I have, and you have them for everything. It should be in that little booklet. I didn't get it. I'll get back to doing the summaries of the treatment plans for you. I kind of got away with the trip and all.
Yeah.
So too much cortisol is insomnia, digestive issues, emotional issues, poor libido, low blood pressure, sugar cravings, lightheadedness, chemical sensitivities, and symptoms of hypothyroidism. So that's the problem when cortisol looks like hypothyroidism. One of the big differences is that the fatigue is intermittent. It comes and goes. They wake up, they're tired. Then it goes away for a while, but in the middle of the morning, 10, 11 o'clock, then they need coffee, they need tea, they need Red Bull, something like that. In the afternoon, they feel like they need a nap. But after that, after the morning fatigue clears, they need a nap in the middle of the afternoon. Then it clears again. Then it comes back again around 5, 6 o'clock. This is somebody who's got a regular routine. If you're working night shift, you kind of have to, shift that and whatnot. And then again, they sort of grog around. And then at 9 o'clock, 10 o'clock at night, they get a second wind and they're wide awake again. And then they have trouble sleeping. And then the whole sort of the whole
cycle restarts.
Yes, resets. There's usually sugar or salt cravings with this also. And that's another key. So it's intermittent. If it's thyroid, it's continuous. It goes, the fatigue, never relents. If it's comes and goes, then that's a cortisol issue. Okay. If it's too low, so remember, too much cortisone, you're going to have low blood pressure. Too much cortisone, you're going to have high blood pressure, sort of the opposite. Again, not enough cortisol, not too much cortisol will leach bone. It's a calcium abnormality, and you're going to end up with thinning bone. You're going to get increases with not enough cortisol, cholesterol and triglycerides. You're going to, again, water retention. So the symptoms are similar, and loss of muscle mass. Okay. Remember that extremely low cortisol levels is a medical emergency. That's an Addison's crisis, and it can be, fatal. So,
Yes, and I had a patient that presented the other day with low blood pressure. I couldn't figure out anything that was going on, but she did take some cortisone on an irregular basis. I ended
mhm,
up giving her some steroids,
mhm.
thinking that she might be Addisonian.
Okay. So again, so for there, then that's where you really need the ACTH, and the AM ACTH and the AM and PM cortisol levels. You
Yes,
sometimes need an ACTH stimulation test. Um, but for our garden run of the mill, patient who comes in and they're menopausal or andropausal, the reverse T3 is good enough, really. Okay. Um, at least first screen. And then we're going to talk when we get further into cortisol, what we're going to do, we're going to look at the
and
saliva
reverse
test.
reverse T3, it's high with
Right.
a lot of stress, right?
Correct. Mm-hmm.
Okay.
Yeah. So, and we'll get into the cortisol, the 4-point saliva test when we get, go into our deep dive there. Okay. I used to do that on everybody. You know what I'm talking about?
4 times a day that you're
Yeah,
checking
yeah,
the
yeah,
adrenal
and you
thing.
get
Yes,
that
yes.
graph and right, yeah.
Yeah,
I mean, like I said, I used to do that on everybody, but it's expensive and none of the insurances pay for it. And again, the
yeah,
reverse T3 is a really good screen that costs about $8. So, um,
gotcha.
and if some of this is once you start listening to the patients and you start
Yes,
recognizing the patterns, some of it is, it's nice to have it if you have it, but it's kind of unnecessary. So,
gotcha.
insulin, I probably don't need to tell you too much about insulin. It regulates glucose production. It counters the action of adrenaline, and cortisol, and it converts glucose into triglycerides. So when you have insulin insufficiency, you're going to end up with hypertriglyceridemia. It maintains glucose at steady levels. It plays a role in serotonin production, and it enhances muscle development. Okay, you still there?
Yeah, I am. Sorry.
Okay. All right. Well, I thought I lost you there. Okay. Insulin dysfunction. Again, too much insulin is usually this is your diabetic. Remember that you become insulin resistant and insulin doesn't work and your body makes more and more until it burns itself out. Too much insulin, you get in excesses, you're going to end up with sort of an aging process, acceleration, acne, breast cancers, colon cancers, depressions, mood swings, low estrogen levels, irritable bowel, coronary artery disease, hypertension, gastroesophageal reflux, weight gain, infertility, insomnia, and then your osteopenia again. So again, remember, insulin, the osteopenia is a factor. Cortisol, osteopenia is a factor. Estrogens, osteopenia, osteoporosis is a factor. So we need to look at all of those. Deficiencies in insulin are bone loss, depression, fatigue, excess thirst, weight gain, dark skin under the chin, groins, and axilla. That's your acanthosis nigrans. Feeling shaky and anxiety, sweating, chills, and hunger, and rapid heartbeat. So that sounds like diabetes also. And so, it's if you're not processing, carbohydrates properly, it could be from too much insulin or too little insulin. Our goal is usually between 2 and 5. Normal on a lab test is about 2.5 to 25. But we want to keep it in a sort of low, steady state. That's where you want it to be. The more insulin you use, the more sort of insensitive we become to it. And again, until it burns itself out, then we have to give you insulin. Now you're a diabetic. 3 minor hormones. You can tell I did this with an AI thing because it doesn't spell anything right. But I thought, but it looks. I think it looks pretty cool. So I
Yeah,
left. Yeah. So I kept asking it to try and spell the words right, and it just kept getting different ones wrong. So I just, I'll leave it in. So DHEA. Um, DHEA, you can consider DHEA a minor testosterone. It basically does the same thing as far as function's concerned, except for that it's neuroprotective, well, as testosterone is. But remember what I just told you. It is the um, antidote for high hypercholesterolemia. Okay, so cortisol, sorry, for cortisol. It improves mood, sense of well-being, energy, bone density, insulin resistance, myelin sheath production, immune function, growth hormone levels in the evening, and it decreases visceral fat, LDL and triglycerides, fatigue, and it alleviates dry eye syndrome. So basically the same thing testosterone does, with that one caveat. And then here I have the same thing. So too much DHEA. Oily skin, oily hair, acne, bossiness, road rage, weight gain, facial hair, sugar cravings. Same as testosterone. Not enough, again, same as testosterone. Depression, moodiness, osteoporosis, memory loss, dry hair, dry skin, dry eyes, scant body hair, noise intolerance. So mold is mold toxicity. You're going to get a visual or light intolerance, and when we get the pregnenolone, you're going to see it'll be light intolerance. So sensitive to bright lights, DHEA, and actually testosterone, noise intolerance. Okay, so
Hey, how would somebody be DHE excess? Taking it exogenally? Would there be any other physiologic way of getting it?
Well, if they're loading up on the precursors, and for some reason it's going down that pathway, so if they're using excess pregnenolone, or if they have really high cholesterol levels. I had a lady come in. I haven't seen one this high in years and years. She was on a carnivore diet. Her total cholesterol was 482, and her LDL was 307. And I mean, even I thought, whoa, she says, oh, I'm on a carnivore diet. I said, wow, you need to do something with this. She goes, no, I'm fine.
Yeah.
All right.
Just flooding the system with cholesterol and making hormones. Okay, got it.
Yeah. Well, she says that ringing in the ears went away. She's got GERD, that went away. She says she feels great just on a carnivore diet. So her cholesterol's high. She says, I'll take it. So
I'll take it.
All right. Pregnenolone. This one, it spelled it right.
Yeah.
All right. It makes nice pictures, huh?
Yeah.
So pregnenolone, your knee-jerk reaction is memory. Okay. That's it. This is the hormone of memory. It blocks the effects of cortisol, as does DHEA. It repairs nerve damage. It stimulates GABA receptors to increase GABA, the calming neurotransmitter. It acts as an anti-inflammatory. A deficiency results in a 100-fold drop in presynaptic GABA mechanisms with decreased neurotransmission, and manifests as panic attacks, agitation, aggression, insomnia, social phobias. Okay, and arthritis, insomnia, memory loss, fatigue, and depression. So, so the two big takeaways. Number one is memory. Number two is anything having to do with GABA or a calming neurotransmitter. Okay.
As you know, I mean, we're having just an overwhelming number of people with anxiety.
Right.
2 or 3 visits a night. We will have people show up at 2 o'clock, 3 o'clock in the morning with anxiety.
Okay. Well, I don't have the pathway here. We'll talk about it. So pregnenolone. Let's go back. Let me see here. Okay. Let's go back just a bit. I want to go back to our chart. So our pregnenolone, all right, is here. Okay. This is pregnenolone. Pregnenolone. Everything comes from cholesterol, right? Stuff we told you not to eat.
Yes.
Right. And then give you drugs to get rid of it. Right. And they work up here. The HMG coenzyme reductase inhibitor. There's a pathway up here. So pregnenolone will go down one of 2 pathways. It'll either go to 17-hydroxypregnenolone and go to DHEA and then the sex hormones, or it will go down this road, and it's not on this chart, but there's another pathway. So from progesterone to dihydroprogesterone to allopregnenolone. I have it on another chart. It sort of goes off on the left-hand pathway here.
Yes.
Progesterone to dihydroprogesterone converts to dihydroprogesterone via 5-alpha reductase. Okay. Same as testosterone to DHT. Okay.
Okay.
When you use this 5-alpha reductase, which is here, there's another pathway that goes here. And what that does is that will block your production, your stimulation of allopregnenolone, which that's what creates GABA, your calming neurotransmitter. And so this is where a lot of your erratic agitation, irritability, even schizophrenic behaviors come from.
Interesting.
Okay?
So by giving some blockers of that, if I recognize that, will help to reduce that anxiety.
Actually, if you give blockers of that, it will actually increase the anxiety because you're blocking that conversion here.
Oh, so we want that.
Yeah,
we want higher levels of
you
GABA.
want this. In fact, yeah. So this is what we'll do: is we'll load up on pregnenolone. We'll give them 400 milligrams. You can use that for about 4 weeks. Then you start getting some side effects, so you'll have to back off on that after that. 400 milligrams of pregnenolone, and you can actually give them even 100. In males, you can give them 100 milligrams. Females, you can go up to 200 to 400 milligrams of progesterone. And you're going to get a natural production of GABA. Your unnatural production of GABA is your benzos. That's how your benzos work, is they stimulate allopregnenolone to produce GABA. That's how they work. But as you know, they're addicting, and there's a lot of drug interactions with them. And there's all sorts of problems, especially with, your opioid crowd. So a way around that is pregnenolone and progesterone. Okay, that's a way to handle it without having to deal with all of the issues that you end up with the benzos. It's a little more expensive, but it's a lot safer.
Yeah.
So if you think about it, so your 5-alpha reductase inhibitors, your finasterides, dutastarides, those kinds of things that block 5-alpha reductase here, also blocks 5-alpha reductase here. And that was something that was kind of not talked about until there's a whole subset of young guys who were taking the 1 milligram finasteride that end up with something called the post-finasteride syndrome. And there's 3 big components to that. And it's about 3% of those who take that stuff. But there were, in 2019, 11 million prescriptions for 5-alpha reductase inhibitors, about 9 million for finasteride and 2 million for dutasteride. And 3% of 11 million is a lot, right? 1% is what, 1.1 million?
Mm-hmm.
And then so a third of that is about 500,000 cases. So it's not nothing, right?
Yes.
And you will see it if you ask. And if you go, you go to where this affected go. If you go on Facebook, there's a finasteride, post-finasteride syndrome, and I've dealt with some of them. These guys are really difficult to deal with. First of all, they were taking the stuff to preserve their hair. And, it can leave them with really severe psychiatric complications. And sometimes it's permanent, and sometimes it doesn't happen until after they stop taking it. So it's a little bit weird that's kind of what happens. But it was pretty predictable. And there's now, of course, there's court cases now, and it comes out that, Merck knew about this. They're the ones who make the trade name. They knew about it, there's papers, they knew about it, and they just kind of buried it and all. So it happens in about 3% of the patients. So 3 big things: they end up with urinary issues, sexual dysfunction, even like Peyronie's disease. It causes scarring in the penis. Just from taking a drug, once a day for to save your hair. And sometimes it doesn't happen for guys who've been taking that stuff for a couple of years. Sometimes they've take 1 pill and it happens.
Holy shit.
Yeah, yeah. So you really need to be careful with it. And if somebody comes in, a young guy comes in with psychiatric issues and he's got hair loss, you need to find out if he's taking this stuff. There isn't any real antidote for it. We load them up with pregnenolone and progesterone.
Hmm.
And then we do some of the peptides for, so they have like sexual dysfunction. So that's one. They get anhedonia. They lose feeling in the groin area.
Mm.
So,
Wow.
30-year-old guy taking a pill for, to save his hair and now nothing works. It's
Wow.
pretty not pretty devastating. Um, then there are the symptoms, they call them general symptoms. The symptoms um, uh, hypothyroidism and low testosterone, and sort of like what the side effects are. So dry skin, dry hair, fingernails crack and break, constipation, can't lose weight, cold all the time, and then low testosterone. So poor libido, depression, anxiety, poor muscle tone, urinary incontinence, erectile dysfunction. That happens in about 1% of the patients. And then the third pillar is the psychiatric pillar. And that happens not as often, maybe, I think the statistic is 0.7%. The last I looked of patients, which again, isn't, remember 1% is maybe 150,000 a year. So
Yes.
a little bit less than that, but that's still a lot of, and these are young guys. These are guys 18 to 43. It doesn't seem to happen again, a paradox that the 5 milligram, finasteride, Proscar, it doesn't seem to happen with the older guys. It's the young guys that this happens to.
And this is finasteride syndrome.
Called post-finasteride syndrome. And at first it was sort of poo-pooed. These are just layabouts and wastrels and all. But there's actually you get lymphocytic infiltration in the erectile tissue. You get scarring in the erectile tissue. I mean, it's a real thing. And the guy said there've been. I haven't looked at it in a little while. I gave a couple of lectures on this 2 years ago. That's why I know this pretty much off the top of my head.
Yes.
And there were the last statistics I looked, there were 178, I think, maybe 180 suicides directly attributed to taking finasteride, and a whole swath of, like I said, less than 1%, but that's still a lot of guys with pretty severe psychiatric reactions to this. And sometimes it's permanent. It doesn't go away, even, after you stop it. So,
Gotcha.
okay. And that this is the explanation for it. It's that progesterone to dihydroprogesterone gets blocked. That's why it happens. So, there's probably some genetic predisposition to it. So anybody who's has a severe family history of severe depression, they've been depressed themselves, also insomnia, chronic insomnia, you should probably stay away from the 5 alpha reductase inhibitors.
I think so. It sounds like some genetic predisposition.
Yeah.
For that.
So. Okay, so let's see. So pregnenolone, that's where we were. So the pregnenolone is very, this one's pretty interesting for something that doesn't get a whole lot of play. And there's a whole new class of drugs that have come on board that are basically, you remember that pregnenolone to allopregnenolone,
Yes.
that are actually synthetic allopregnenolone that stimulate allopregnenolone to make GABA, which is way better actually in theory than your SSRIs. So in theory, it should work quite well. Now, there are last August it was FDA approved as a pill. It's been around since it's called Brexanolone. It's been around since 2019. It was approved for a postpartum depression in an IV form, and the protocol was IV Brexanolone for 60 hours for postpartum depression, and it's pretty impressive as far as how well it works after for this versus the usual culprits, the Prozacs and Zoloft's and things like
Mhm.
that.
Wow.
You get about a 60 to 70% better response, and you get a quicker response too. Usually 3 to 5 days, and the symptoms are pretty much gone. The
And
problem
you say it's IV?
Yeah, it's the IV form. The problem is the protocol calls, it has to be an inpatient protocol because there's one little quirk with this, and that is it can cause sudden loss of consciousness, which would be a bad thing if you were driving with
Yes.
no warning. Okay. So, so the pill form, there is a pill form, and it was delayed until last summer. It was finally approved. And I thought it would be that they had done something to it. The company that makes this is called Sage Therapeutics. I would thought that they'd maybe altered it some way to be able to to get around the that loss of consciousness, but apparently not. There's a black box warning on it that if you take take the oral form, you're not allowed to drive for 10 hours afterwards. So I mean that's how they got around it.
So is it a combination of pregnenolone and progesterone?
No, it's a synthetic allopregnenolone. That's what it is.
Okay.
That's what it is. Okay. And so, you remember Bing Crosby, accentuate the positive, eliminate the negative, right? So the
Yes.
positive is instead of using the benzos or even doing it the way we do, but, loading up on pregnenolone and progesterone, you're directly stimulating allopregnenolone, which is what the benzos do, but with lots of side effects. And then so again, the one big bugaboo here is that you can go out suddenly with no warning. So so I don't if they give if this is this is not widespread use obviously, but if we could get around that, it would pretty much revolutionize the way depression is treated.
Fascinating.
Because
Let me ask you,
it works
you mentioned,
really, I mean, it works really well and it works really quickly. I mean, 2 weeks, long-standing depressions are gone.
really, you mentioned nerve repair, nerve damage.
Right.
So no doubt this is part of your brain protocol, correct?
Absolutely. Yeah. So this is part of our protocol for everybody.
Yeah.
You'll notice on our lab draw, we draw this. And 90 to 110, I forget the units, we'll come across it as we get there.
Yeah.
Is our kind of our sweet spot. It doesn't always correlate with memory issues and nerve loss. For example, me, last time I measured mine, I got a 0.
Oh gosh.
Yeah. Now my memory's pretty good, but when it comes to names and things, if I
Yeah.
even medications, supplements, I know what I want. I know what I'm thinking of. I know what it looks like, and it takes me a minute, or sometimes, or it doesn't even come to me at all. I have to go look it up, and that's been happening for a little while now. So, some patients will tell you that. So usually when we go through the lab slip, through the lab, when I get to pregnenolone, I'll ask them how their memory is before I tell them what it is. Because I don't think I've come across.
Let me ask you a little sidebar.
Yeah.
It's my impression, it's my thinking that um, ringing in the ears, what is the it occurs with a little bit of deafness, dizziness, and everything is actually a neuropathy of the eighth nerve.
Right.
Have you ever been treated any of those people and had them get better after treating?
Some, yeah.
Uh-huh.
So it's a combination of things. So I do acupuncture. That seems to help stimulate circulation. And the way we do it is we put if you go behind your ear, there's a little flap of tissue there that attaches
Yes.
your right. We put a needle on the top and on the other side, and then we put one right by the right halfway down the sternocleidomastoid. Where you sort of manipulate. If they have an irregular heartbeat.
Yes.
Or
Vagus
panic
nerve.
attack. Yeah. So we put a needle there, and then we'll use something called it's a micro stimulator. We have it's got two negative grounds and a positive ground, and we'll stimulate that. And what that does is causes a contraction in the muscles there, and it allows any fluid that build up to drain out.
Oh,
So,
okay.
so that's one thing that we'll do. We'll use, if they have too much vitamin D, that's if their vitamin D is too high, you'll see this. If they have again, if that doesn't do it, DD, what's the ADH?
DDAVP?
Yeah, DDAVP. You can use it in a pill form or in nose spray. That's a regular prescription. You don't have to compound.
Yes.
Usually 0.1 milligram. Most of the time, I'll just use the pill form. 0.1 milligram. It comes 0.1 and 0.2. Usually start at 0.1. Sometimes I'll use meclizine. That's regular doctor thing.
Yeah.
Yeah, and then yeah. So check their vitamin D, DDVAP, the acupuncture. There's something else. Yeah, it'll come to me. There's something else,
Magnesium?
huh?
Magnesium?
Yeah, magnesium, zinc. And any all of those minerals. So
Yeah. Gotcha.
okay. Okay.
Great.
So the only time you're really going to see really high pregnenolone levels is one, if they have a pituitary adenoma, or two, we're giving them pregnenolone and overshot the mark. So,
Okay. Gotcha.
so mostly we do it. Okay. And quite frankly, again, so it'll be excess drowsiness, sleepiness, that kind of thing. Quite frankly, I've had people come in with pregnenolone levels of 300-400, and they're you've never seen any of this. Okay.
Gotcha.
If it's too low, again, brain fog, forgetfulness, depression, insomnia, those kinds of things. Okay.
Yes.
Again, if it's too low, and you will see that, and it's pretty prominent. Okay. And it's, like I said, it's part of our routine workup. And we also do prolactins. So traditionally prolactin, as you're looking at it, if it's high, that's your pituitary adenoma and everything that goes from that. And if you do your pituitary hormones, they're all off, or 3 or 4 of them are off. There's 6 total. 3 or 4 of them off. If one is off, that's not going to be it. But if ACTH, LH, FSH, TSH, growth hormone, if they're all high, then that there's a pituitary excess.
Oh, okay.
We're looking for actually low pituitary function. So low is less than 6.0. And this is indicative of a treatment-resistant either anxiety or depression, chronic panic attacks, fidgetiness, restlessness, aggressiveness. They're always on edge. And for guys, it can be erectile dysfunction and premature ejaculation, those kinds of things. We found this in the head injury guys. Okay, the military guys with head injuries, and their prolactin levels are low. If the prolactin levels are less than 6.0, usually you're going to find some sort of behavioral issue, and they're not that easy to correct. The problem is that the pathways of the routine medication. So SSRIs, those kinds of things. Those are all chemical reactions, and they rely on the fact that the neuronal connections are intact. But if they're not, they don't work. And so these guys, they come from the VA. They're on two antidepressants and 2 anti-anxiety agents, and then they're on 3 other drugs to counteract the side effects of the first 2.
Yes.
They're always looking for, Godot. They went to 2 psychiatrists, the psychologist, the Reiki master, the iridologist, the shaman, the faith healer. They went to India to the ashram, and nothing ever seems to work. And then they latch on to whatever is the latest and greatest, whatever, lately, now it's the internet, whatever the internet guru is saying here, this is going to cure you. And you'll see these people. I mean, they're actually pretty common. We found this in the head injury guys that came back from the Middle East, with the blast injuries, that kind of thing.
Yes.
and you'll find them, and the prolactin levels are quite low, and they're on all sorts of antidepressants, anti-anxiety agents, and nothing seems to work.
So it's a chronic condition.
Yeah.
Then it doesn't. Well, okay, and these patients,
So they
it
have,
persists for months and years.
they get involved with a head injury, and this doesn't show up right away. This shows up. This takes 3 months, 6 months, a year, 2 years to show up. When they start out and they start having personality changes, antisocial behaviors, those along those kinds. These are they show you the guy standing under a bridge screaming at the sky. Here's Joe Soldier, and we've abandoned him, right? And
Yes.
that's who shows up with these low prolactin levels. Now, one thing I used to, I don't do it anymore because I can't stand them, but I used to do insurance physicals for lawyers. A guy who was in a car accident, or a lady was in a car accident, and now they can't work, and we got to say that it was it was the car accident's fault, and as soon as the check clears, all of a sudden they're better.
Yeah.
Well, if they have any sort of neurological claims, that deficits, that kind of thing, they can't think, they got brain fog, all of that. Without telling them, if you look at when you draw a prolactin level, if their prolactin levels are normal, they're faking. Okay. If they're under 6, they're probably telling you the truth, right? Even if it's 6.5, 7. But if they have adequate prolactin levels, and they're telling you that they're dweebs and they're basket cases and they can't do anything, I don't tell them. Well, I don't do this anymore. I don't do it anymore because I can't stand them. But I can't stand the lawyers, and I don't want to go be doing depositions because it's just not me.
Gotcha.
But you can tell. I mean, you probably can't get a prolactin level in the ER, but just think about it.
Mm-hmm.
Right? I mean, and the prolactin levels will change within an hour after a head injury.
I think the other thing that we do with prolactin levels, I think we draw them if they came in with a pseudo seizure, and if it's not elevated, then it wasn't a seizure. Very interesting. Yeah.
Right.
Okay, cool. Love it.
Okay, so it's about 7:30. If you want to do a little bit of lab, we can do that.
Yeah, sure.
I probably got about another 15 minutes. Okay.
Yeah.
So when we talk about labs, we can do a serum, you can do urine, you can do spot blood test, you can do saliva tests. I'm pretty comfortable with the serum tests. When I moved to Nevada, they basically told, and we were doing the saliva test. They basically told me, if you don't do the serum test, it doesn't count. That's what the medical
reps will tell you. Yeah.
That's what the medical board said here. So,
oh yeah. Okay.
So we were doing both, and then I sort of got away from doing the serum test. So I think I have not in this section, but when we go through some of I have a whole thing just on labs. But this is just sort of a survey or an overview, so it'll get you sort of up to speed. We basically want the labs to be mid-range to upper third of the normal range, right? Okay. These ranges. So the example I always give is vitamin D, because the numbers are fairly easy. So most labs, the big labs, vitamin B, the normal is 30 to 100.
Yeah.
All right. So that means 31 is normal and 98 is normal. 29 is not normal. 31 is normal.
Yeah.
31 and 98 are considered the same. 29 and 31 are not. That's the way I explain it, and that usually rings a bell. And said, "Oh yeah, that doesn't make sense at all."
Yes.
Right. And so then I go through how we try to find our optimals, and so the basic way what we do is we find the midpoint. So again, we'll go back to vitamin D. 30 to 100 is normal. 30 and 100 is 130, and divide by 2, 65. Okay. Now, where those numbers come from, the 30 to 100, where those numbers come from?
The general public.
Yeah.
Which many of them are unhealthy.
Right. Yeah. It's 2 standard deviations of a random population. So 2 standard deviations is 95.4%. It's no different than if we would go up to the college here and take a pass-fail class,
Yes.
you know who passes? 95.4% of the class. It's a
That's right.
mathematical model. It came out of architects and engineering in the 40s and 50s. The lab industry decided in the 60s and 70s they were going to use the same standard. And I guess it works reasonably well, but there's a lot of sort of nuance to it. So back in the day when I graduated and you graduated from the College of Osteopathic Medicine and Surgery, which is not called that anymore, the normal cholesterol, the top number, you know what the normal cholesterol was? The high?
Remember.
350.
Okay.
All right. And I remember because I had spent some time at the Pritikin Clinic when I was a student. Nathan Pritikin he was one of the first low fat.
Pritikin.
Yeah.
Yeah. Oh, yeah.
Yeah. We had a month off. We had to do like an apprenticeship, and I went to Santa Monica. He had rented a hotel, and they put an ad in the newspaper. If you had a heart attack, and it was all men. If you had a heart attack and you were told to go home and die, because basically that's what they told him to do back then. Stay in bed for 6 weeks and don't do anything.
Yeah.
That was basically the standard treatment. Come to us, we can help. And so we put him on a 10% fat diet, and we made him walk every day. They started out, as far as they could go. If they could go 30 feet, that was it. Then we made them go 50 feet. And we usually got them by after they'd stay for at least 2 weeks. We get them to go for at least a mile. And we got some regressions. We actually did okay, but who wants to be on a less than 10% fat diet? It was,
Yes.
So
at the hotel, you could control their diet 100%, right?
Yeah. Well, it was like an all-in-one thing.
Gotcha.
I think they paid $100 a night to stay there, which was, a fortune back then. And we gave them
interesting story. Yeah.
Yeah, we gave them niacin, we gave them fish oil. Same stuff we do today. I don't think we used red rice yeast. I think we gave them they used a lot of garlic in their recipes, because they controlled what they ate. I remember when I first went into practice, we didn't. I got a rejection on a medical visit from Medicare because I put down hyperlipidemia as the diagnosis, and they decided that wasn't a legitimate reason to have a medical visit. That was in 1982. That was before there were statins.
Yes. Before we could figure out that was a profitable business to be in.
Right.
Yes.
Mm-hmm. So. Okay,
wow.
So again, you want it in the upper half to upper 3/4 of the median.
Yeah.
Okay. Here's your workup. Okay.
Okay.
So this is what we do. Okay. And I think you should have this already. But so we do all of these things. Okay. I think it looks like here testosterone. We do also do sex hormone binding globulin. I need to fix that. Let me do that right now. Okay, since I got this here.
Gotcha.
We do it for both. Okay, sex hormone binding globulin. We do it for males and females. Okay, so okay, let's go back to that. Okay, so all right, looks like you're fading here.
Yeah, I am, but I'm okay.
All right, so okay, so we'll go through these and then we'll call it a day for now. Okay.
Yeah.
So these are all the labs that we do, and these are the markers, and I actually put some of the remedies here. So C-reactive protein, that's an inflammatory marker. You can do an HSC reactive protein. That's the one we do now. It's for cardiovascular damage. Normal is 0 to 3. Our goal is less than 1.
Gotcha.
Anything over 1.0. We like omega-3 fatty acids, and go up to 4 grams a day. So this weekend there was somebody who gave a talk who talked about omega-3 fatty acid. Forget what he called it, clusters or units, and he does 3 units. Each unit is three grams. So it gives
Ah.
9 grams for a week, then he gives 6 grams for a week, and then he gives 3 grams daily after that, sort of a loading dose. So that was something that I probably heard somewhere along the line a long time back, but this is the way I do it. I usually start with 1,000 milligrams twice a day, and I tell them if they're forgetful, and they can take it, they can take it all at once.
Okay.
Curcumin or turmeric, I usually save this for if they have joint pain, neck pain, back pain, that kind of thing. In the pill form, it usually comes 500 milligrams. And again, 1 or 2 in the morning, 1 or 2 at night. For curcumin, make sure that it has bioprine in it, has black pepper. Otherwise, it doesn't get absorbed. Okay. So
How do I look for that? Does it say that?
it'll say it right on the bottle. Yeah. We use, again, we're not CMEing here, so I can tell you. So we use pure encapsulations. That's the one we like.
Oh yeah, gotcha.
Okay. All right. And just as an aside, Douglas is actually the same company as Pure. It's got different label, but
Really? Okay.
yeah, it's the same company. Okay. Orthomolecular has one called Tervia, something like that. It's also curcumin. They're usually pretty reliable also. Okay.
Gotcha.
When we do blood sugars, I always tell the patients it's like the Christmas Carol. The Christmas Carol is we look at the ghosts of the past, present, and future.
Yes. Uh-huh.
Blood sugar, we do the blood sugar of the past, present, and future, and they're right there. So the past is hemoglobin A1C on average over 3 months. Normal is less than 5.7. That's pre-diabetes. Higher than that, greater than 6.5, that's diabetes. Optimal is less than 5.3. Okay.
Gotcha. 5.3. Gotcha.
Right. Present is the fasting blood sugar. Normal is 65 to 99. Optimal is 65 to 84. And the future, you can take your fasting blood sugar, every point over 84, there's a 4% chance of developing a blood sugar abnormality. And when we go through, I can get you the reference on that. Okay, so a blood sugar of 94 is normal, fasting blood sugar, but that's 94 minus 84 is 10 times 4. So there's a 40% chance of a glucose abnormality within the next 5 to 10 years. So it's kind of a predictive value. And so, that can be changed. But again, I can get you the reference for that.
Gotcha.
It's in the notes somewhere.
Okay, that's right.
Okay. And then we look at insulin also. Normal is 2.6 to almost 25. We want it less than 5.
Okay.
We can also calculate insulin resistance, which is a fasting blood sugar times fasting insulin, not inulin. I should fix that. Divided by 405. That'll give you the correct units. Normal is less than 2.9. Optimal is less than 1.9.
Okay. Insulin resistance. That's
insulin resistance. Yeah, that's how you figure it out. Okay. So again, it's another sort of calculation that'll give us it'll give us a sort of a handle on how you're handling blood sugars. Okay.
Gotcha.
Homocysteine is a marker for nutrition and sometimes a marker for heart disease. It's a marker for damaged blood vessels, increased blood clotting, strokes, heart attacks. Someone with a Leiden factor 5, this will be high. Normal is less than 11. Optimal is less than 10. And our remedy here is methylated B vitamins. Lots of companies make them. They have some peripheral things in them. A lot of them actually have betaine and some digestive enzymes in them also. The one we like is methyl SP. It's from Apex Energetics. But there's all sorts of companies make them. Okay, but it has to be methylated. The equivalent is, I always tell them, if they go to Costco and get a big bottle of B vitamins, they need about 10 of them 3 times a day to be the equivalent of the methylated one. Vitamin D.
So I do know of MTHFR, that process fairly well.
Yeah. Vitamin D, we talked about how to get that. 50 to 80 is our goal. Okay. Estrogen, remember there's 3 types of estrogen, 1, 2, and 3. So ESTRONE, 1, that's the bad guy. right?
Yeah.
If this is what you're going to find after, it should be after menopause, also after hysterectomy. We want that to be less than 100, okay? If it's greater than 100, we're going to use 7-keto DHEA, start at 25 milligrams, go up to 100 at bedtime. And it will improve it will decrease by 25 to 40% within 6 to 8 weeks, the estrone levels. Okay, this was the stuff Dr. Oz was hawking for weight loss 20 years ago on on his show. This was one of his weight loss. 7-keto DHEA was one of his weight loss recommendations. So,
Oh, I think.
so again, estrone will hold fat in the abdomen. And so we decrease the estrone levels. You're going to decrease fat in the abdomen. Makes sense, right? Estradiol.
I don't see treatment. So the
No, I
treatment
don't
is,
have that there.
yeah,
Again,
gotcha.
we'll get to that here. Estradiol. There's a big controversy about blocking estrogen in men. I'm still of the opinion that it should be somewhat controlled. Optimal is about 15 to 25. Usually once it gets over 40, we start getting, labile emotions, and we start getting things like, gynecomastia, man boobs. And there's a whole argument for not blocking estrogen. They say,
Yes.
but we used to take it to an extreme. I think that's what the issue is, really. When we first started out, we would get the guy's testosterones to 1,500 and the estrogens to 0. That's what we did. And too low estrogens, you will, for a long period of time, you will end up with osteoporosis. You'll end up with behavioral issues. So estrogen does drive blood flow to the brain. You're going to get memory issues if the estrogens are too low. But I think the literature that I've looked at is pretty clear that, as long as you keep it in the 15 to 30 range, you're probably okay. Once you start getting over 40, you're going to start seeing some of those symptoms. My pal, the guy I told you about, who gets guys' testosterones to 2000s and lets the estrogens run to 150, 200. He was there heckling everybody in the front of the room in the hormone section over the weekend in Florida. So we had some fun with him.
Okay. Let me ask you this. So my seeing lots of different patients, some of them PCO, some of them a lot of them obese, that we've got levels of hormones, and then we've got levels of sensitivity to those hormones,
Right.
kind of overlaying this. So you're trying to you're paying attention physiologically about what's going on with the patient, and you're trying to make sense of it also with the laboratories, but you're moderating the laboratories too, correct?
Exactly.
Okay.
Yeah, I mean, you always have to match what we see here at the labs with symptoms. Okay.
Yeah.
I never, otherwise you just send me labs and I'll tell you what to do. That's a no-brainer, right?
Yeah. Interesting.
Right. But everybody's different. Sometimes you're going to get our antidote for estrogen, too much estrogen, is progesterone. But on occasion, you're going to find somebody where you give them progesterone and the estrogen symptoms get worse.
Yeah, interesting.
So you need to know what to do with that. I mean, it happens, probably about 5% of the time. So progesterone is the second half of your cycle. And low progesterone results in agitation, irritability, can't sleep, poor libido, headaches, short-tempered. We call it an estrogen-progesterone ratio. The estrone plus the estradiol divided by progesterone, and you don't have to correct for units on this one. You want that to be less than 250. If it's less than 250, your patients are probably feeling pretty good.
Okay.
Okay. Now you have to remember that if they're still having periods, you have to get the progesterone and the estrogens at the right time. If you get it in the follicular phase, you're going to have pretty much zero progesterone.
Right.
If you get it in the ovulatory phase, you're going to have a little bit of progesterone. So you really need to draw it really days 19 through 21 are your optimal time.
I see. Wow.
Early on,
I
Yeah.
guess that's kind of hard to
Yeah.
catch
Sometimes.
sometimes.
Yeah. So you need to be able to interpret it because, you know, if somebody comes in with no progesterone and they're having a regular cycle, then you probably got it at the, too soon.
Gotcha.
Okay. Progesterone estrogen ratio. This is what we did originally. This is, you'll see this a lot more in the books than the one that I gave you. Because early on we didn't we're able to get estrone levels.
Mhm.
So the progesterone estrogen ratio, what you need to do is you need to take the progesterone and multiply it by 1,000. That'll get you the proper units and divide it by the estradiol. Our goal there is 100 to 500. If it's less than 100, it's estrogen dominant. If it's greater than 500, it's a progesterone dominant. And again, rarely, like pregnenolone, the only time you're usually going to find progesterone dominance is if we did it. We give them
Oh, I see. Okay.
Okay. It's pretty rare to get progesterone dominance. Okay.
Or I guess if they're on a progesterone birth
Yeah.
control.
Well, that's what I said. We did it. Right.
Yeah.
Okay. Now you're going to get somebody who's menopausal, and it'll read an estradiol of less than 5, which is basically 0. So
Yes.
I usually just put a number in there like 0.01 just to give me a number
Gotcha.
to work with. Or you could just look at so estrogen or progesterone estradiol ratio, if it's less than 0, less than 1, basically 0. So you can call it infinity.
Yeah. Okay. Gotcha.
Okay. Okay. I'm getting a thing that I got 10 minutes for.
Yeah. Gotcha.
So
We can wrap up.
I need to take a little break. Let's just do the testosterone, and then we'll take. Well, you know what? Let's stop there because the testosterone and sex hormone binding globulin go together. So, I'm gonna wrap it up there, and we'll talk about this. We'll do this.
Okay.
Pick it up from
Next
here.
week. Yes,
Yep.
sir.
Okay.
Thank you
Anything you
very
need me?
much.
Anything you need me to send you?
No, if you have a chance, I believe that I sent my Cyrex laboratories to you.
Okay, I'll go look at that.
Yes, sir. No
Okay.
hurry. And
Okay.
I'll remind you if you get
Okay.
Thank
All
you.
righty. All right. Thank you. Stay well. If you have any
Yes.
issues, let me know.